All right. Hello, everyone. Happy Monday. Welcome to a Clinical Reasoning virtual morning report. Today, I'm really excited for the session today. As the case discussant, we have Dr. Rebecca Berger, who is an academic hospitalist at Weill Cornell, a New York Presbyterian hospital. So Rebecca, thank you so much for being here and taking the time to be the case discussant. Before we jump to the session, I was wondering if you could just briefly describe kind of how you decided to pursue a career in hospital medicine. And then maybe also if you have any kind of fun hobbies or like highlights from the weekend you'd want to share.
Absolutely. Thank you so much, Maddie. And it's so nice to see everyone today. I've been kind of participating and showing up at VMR on and off for the last couple of years since it got started. And I'm really honored that you guys invited me to be a discussant. I by no means feel and consider myself an expert in clinical reasoning, but since it's something I do every day, I'm happy to kind of show off how that works on a day-to-day basis as a hospitalist. So why did I become a hospitalist? I think, I went into internal medicine residency really not sure what I wanted to do. I think like many ultimate hospitalists ended up considering multiple different paths, including primary care, infectious disease, critical care. There was really something about every specialty that I loved. So I think what I realized was that it was really the interplay between different organ systems that I loved. And I really do enjoy being the kind of person who has ownership over the patient's care and the patient's outcomes, at least for the short time they're in the hospital. I like being the one that communicates with patients' families, often helping being the kind of translator or liaison sometimes between a subspecialist's recommendation or diagnosis and the patient. And I also really like the pace of hospital medicine. I like the acuity of the diagnoses. I like that people are coming in with a complaint or an abnormality, and it's really my job to kind of figure it out in the way that I think many internists really embrace. So it was all of those things together that led me to a career in hospital medicine. And so far so good. I don't know, 8 years in, almost 7-8 years into hospital medicine, and don't anticipate leaving anytime soon. So yeah, that's that. And in terms of hobbies, I told you, Maddie, a few minutes ago, I have a 4-year-old and a 1-year-old, 2 boys. And so I think anyone else on the call who's a parent probably knows that hobbies don't really exist at this stage of parenting. I spend most of my time playing Lego and Monopoly Junior and changing diapers and trying to get sleep when I can, which is hard to come by. So yeah, they are kind of my whole world outside of work these days. And maybe call me in 5 years and I will have picked up a sport or a art, a hobby, but not in the foreseeable future. But we did take the boys this weekend. We live in New York City, so we anytime it's a nice day and we have nothing concrete on the schedule, we try to find some new fun adventure. So we took them down to this area of New York called Hudson Yards yesterday, which is this kind of beautiful new development with all these big buildings, and there's it connects to something called the High Line, which is an elevated old railroad track that they turned into a public park. So it was a fun adventure on a nice spring day.
Amazing. That sounds wonderful. Well, Rebecca, thank you so much for being here. And as I said before, your kids are welcome to come in, share their own clinical reasoning.
I think they will, whether or not they're invited. So
yeah. Awesome. Well, the case presenter today is our own CP Solvers team member, Yusuf. Yusuf, do you want to unmute, introduce yourself, and maybe share like a highlight of the weekend you had?
Hi everyone, I'm Yusuf. I'm currently a PGY 2 in internal medicine. And like Rebecca, I love everything. Every time I go to a rotation, I find myself loving the rotation. Like went through cardiology and I loved it. Went through critical care medicine and I loved it. And after I finish every rotation, I'm like, oh, I want to do this specialty. But similar to Rebecca, after doing everything, I realized that I probably want to do hospital medicine since it involves whole body medicine. And I love interfacing with patients, which is a fun part of every day. This week has been pretty good. I'm on my ICU rotation and I get to admit patients on my own overnight and then the next day reflect on what I did correctly, what I should have done differently. And it's definitely been a week of growth and interfacing a lot with patients, which I thoroughly enjoyed.
Awesome. Well, we can jump into the session now. So Noah, thank you so much for scribing. So you can go ahead and share your screen. And Yusuf, feel free to jump into the first alquat whenever you're ready.
Yeah, so this is a case of a 23-year-old female who is presenting for nausea and vomiting for the past week.
Awesome. Should we start there?
Yeah, with just a few words, Rebecca, maybe we can, how do you think about nausea and vomiting in a young woman?
Absolutely. Thanks for this. I feel like we could talk forever just about this one line, which is what makes this time fun, because on regular, work days, morning rounds, we don't get an hour to just dissect a case. So this is exciting. So the first thing that strikes me is the patient's age. 23 is definitely way below average for the patients that I take care of in the hospital. It makes me think about a few possibilities. One would be, most 23-year-olds are otherwise healthy with no significant medical problems. And if that's the case, then we have to think about, what might have acutely happened to this patient. Is it what we would call bad luck? Did they contract something, whether it's an infectious syndrome or, do they have bad luck because they have, a new malignancy or an endocrinopathy or something like that? Do they have bad genes? Do they have some type of genetic syndrome that might be kind of unmasking itself at this time? So again, her age is really the most striking thing to me to begin with. If she was previously healthy, what happened newly, what happened acutely to make her get sick? The other possibility, and anyone here who's in med peds or family medicine has probably seen plenty of 23-year-olds who are not otherwise healthy. There are many young adults like her who have come from a childhood of chronic illness. Again, whether that's a genetic disease or an immunodeficiency or a history of cancer, right? So I'm going to want to learn, and I'm sure Yusuf will tell us soon, a lot more about her past medical history, because that will really inform the background to the discussion we have here. So that's my first question here, is just young age is striking. Is she previously healthy or not? And that'll kind of take me down slightly different paths in terms of how I'm framing this case. In terms of nausea and vomiting, a few people have said this in the chat already. Of course, the first thing you want to do in a 23-year-old woman would be to check for pregnancy, common things being common. I assume, Yusuf, this isn't a case of new pregnancy, or maybe if it is, there's going to be some twist to it. I'm qualified to do nothing in pregnancy except to make the diagnosis and then very expertly hand it off to my colleagues in family medicine or OBGYN. So that's obviously one possibility, but I think what's interesting is to think about pregnancy as one diagnosis within a category, which would be endocrinopathies, right? You could imagine nausea and vomiting being not just from pregnancy, which again, in hyperemesis or even just kind of traditional vomiting in pregnancy, you would think about elevated progesterone levels and elevated HCG driving that syndrome, that symptom. But you could also think about other endocrinopathies, including something like adrenal insufficiency, which is a rare diagnosis, but something that can cause nausea and vomiting, as well as abdominal pain that's otherwise what we would call imaging negative. So we'll see if she ends up getting abdominal imaging. But I assume that something like hyperthyroidism might also cause some GI symptoms, although maybe not the only presentation. So that's kind of one bucket. Obviously, we want to think about GI, primary GI illnesses, something as benign as a viral gastroenteritis, or a gastritis, something like that, but also something like an H. pylori or other infections of the GI tract. If this patient had a history of diabetes, I might be worried about something like gastroparesis, which of course also has another very long list of causes, but diabetes is for sure the most common. So if you're telling me in a few minutes that she has a history of type 1 diabetes, I'm going to want to learn more about the control of her diabetes and, what her management has been. The other thing to think about would be substances and toxins. So that would, any type of drug intoxication or even drug withdrawal might cause nausea and vomiting. There's also this diagnosis called cannabis hyperemesis syndrome, which is this kind of essentially cyclic vomiting type syndrome that's associated with patients who use marijuana. I think about cannabis hyperemesis syndrome or cannabinoid hyperemesis syndrome and cyclic vomiting syndrome as kind of a spectrum of disease, where if patient has cannabis exposure, the first step is to withdraw that exposure. And if they're still having symptoms, you might end up diagnosing them with cyclic vomiting. So those are some of my initial thoughts. Again, we're thinking about endocrinopathies, we're thinking about substances, primary GI issues. The last one to think about, which I hope is not the case here, would be nausea and vomiting as a symptom of CNS disease. You know, if somebody has increased intracranial pressure, that can cause nausea and vomiting, whether that's from idiopathic intracranial hypertension, used to be called pseudotumor, or from a brain tumor, God forbid. So I hope that's not the path we're going to have to go down today in a 23-year-old, but I think this symptom, you know, complex of nausea and vomiting is just so nonspecific. And I think it's very easy for us to kind of start thinking really quickly about the GI system, because that's where the symptom sounds like it's coming from, but recognizing that nausea and vomiting can be a symptom of a much bigger problem. I've even seen patients with pyelonephritis and sepsis where their first presenting symptom is nausea and vomiting. So I think I keep adding categories to the list, but I think just goes to show how this specific symptom as a chief complaint really could take us down a lot of different paths, depending on both her baseline medical kind of status and conditions, and also, you know, what other symptoms we're going to find.
That absolutely incredible differential. I loved how you kind of highlighted the young age here, and kind of, I liked the framework like bad luck or bad genes. So bad luck being kind of otherwise healthy, or bad genes like kind of genetic disease, and walking through the various categories that could be causing the nausea and vomiting. So really incredible discussion so far. Okay, Yusuf, let's jump to the next aliquot.
Yeah, well, I really loved also the framework you had of like structural image positive versus motility based, and then you go through endocrine and CNS. I really loved that framework. I don't think I framed it that way. I thought it's very good. So a little bit of past medical history. So the patient has a history of spina bifida with a myelomeningocele. This was unfortunately complicated by a neurogenic bladder, causing recurrent UTIs in childhood. This eventually caused end-stage renal disease, and she's post a kidney transplant almost 10 years earlier. She reports some fevers and chills at home for the past week, in addition to feeling cramps, nausea, non-bloody, non-bilious vomiting, maybe 3 episodes per day, decreased PO intake, vague abdominal pain, mostly in the upper to lower quadrants. Does not report urinary symptoms, although of note, she has not had urinary symptoms in the past in the setting of infections.
All right, so we got some more information here, you know, the abdominal pain, fevers and chills with this pretty significant past medical history. So Rebecca, how is that kind of influencing the differential at this point?
For sure. Definitely kind of reframes the case for me in some way, because I think my first instinct was 23-year-old equals previously healthy. And that's obviously not the case in this situation. So you're telling me that she has a history of spina bifida with a myelomeningocele. And I can tell you that my neuroanatomy is rusty enough that I can't think right now about whether that would be something that might increase her risk of increased intracranial pressure. You know, and so that's something I would want to read about, think about, probably consider head imaging, depending on where else we go. But the more interesting thing here is you know, what you just suggested about her neurogenic bladder, her recurrent UTIs, and her kidney transplant. So those two things kind of make the situation more complicated for many reasons, right? So the first one is the neurogenic bladder with the recurrent UTI. So I think using kind of base rate probability in the patient's history, obviously we're thinking about UTI and the differential. And I think I mentioned in the first discussion that I've seen patients with pyelonephritis or UTIs or sepsis present with nausea and vomiting as their primary symptom. So I think that's something that's definitely rising to the top of my list here. And one of the most helpful questions we can ask patients when they're coming in with a symptom, whether it's chest pain or any other symptom, is, does this feel like the last time you had X, right? Does this feel like the last time you had a heart attack? Does this feel like the last time you had pyelonephritis? Because many patients, especially patients who unfortunately have had recurrent or episodic illnesses, they know what something feels like to them. And I think we really need to respect the patient's symptoms and their history and understand that they're the ones that are able to often best report their symptoms. The one caveat I will say to that is that I am a great skeptic of the diagnosis of UTI. And I think there are many patients, millions of patients across the world every day who are appropriately diagnosed with UTI. But I've also seen UTIs as what I would consider being overdiagnosed often. And the most common scenario in which I feel that happens is in a patient who has dementia, who has maybe a slight increase in their agitation or confusion. And, they come into an ER or they're in their nursing home and someone sends off a UA and they find 25 white blood cells and somebody just says, oh, okay, they must have a UTI, and they treat them. And I think that's a bit dangerous for a few reasons. Number one is that many of these patients, so about 30% of community dwelling older adults and 50% of nursing home or institutionalized older adults can have chronic bacteriuria, colonization. And so you're obviously subjecting them to courses of antibiotics that might increase their risk of resistance, as well as side effects like C. diff or acute interstitial nephritis. But the other danger I always worry about with overdiagnosing UTI, and I think that will be relevant here, is what else are you missing, right? And I think that there's a common problem of kind of what I would call premature closure or anchoring in cases like that. And I think we're going to draw some parallels. I promise we'll get back to this young patient's case where, once somebody sees those 20 white cells in the urine, they say, oh, this must be a UTI. And then they stop thinking and they stop looking. And I can tell you that I have had patients who have had strokes that are missed because someone has blamed their altered mental status on their positive UA. Patients who have been bacteremic, where nobody thought to look, no one thought to check blood cultures because they were like, oh, this is just a cystitis. And I think that's where I get very skeptical about the diagnosis of UTI. And absolutely, I will tell you, every time I'm on service, I treat at least a couple of patients for UTI. So it's a real diagnosis and I believe it and I treat it all the time. But I always second guess it. And I say, do I really think that's the diagnosis? What else could I be missing? Is this really an appropriate time to start antibiotics for this patients? Yes, thank you. Yusuf just shared an awesome article from the Things We Do for No Reason series about undifferentiated urine testing in patients who are delirious. It's an appropriate part of the workup. It just can't be all of the workup. And I think that's where we often go awry. So let's try to draw some parallels between everything I was just saying about older adults to this patient. So I think, again, on the one hand, I want to hear a lot more. And Yusuf, I'm glad you already started to tell us about what her symptoms of her prior UTIs have been, right? It sounds like she's been through this before. And with a neurogenic bladder, I'm not surprised at all that she does not have urinary symptoms. So it is very common that she would not have, and expected that she would not have, the kind of classic dysuria, frequency, urgency symptoms that you might expect in a 23-year-old who's otherwise healthy, who hasn't had this history. So, we don't want to kind of exclude the possibility of UTI here simply because of the lack of urinary symptoms. That's quite common in this patient. But I'm also going to be looking for some confirmatory data to kind of argue for the diagnosis of UTI, whether that's a fever or other signs of systemic inflammation like a leukocytosis. I'm also going to be thinking about whether she might have CVA tenderness, right? Even if she's had a neurogenic bladder, she might have tenderness over her kidney, but we'll get back to that because her kidney might not be in the place that you expect it to be. So those are some thoughts I have about her recurrent UTIs. I want to get a good history about her prior UTI history, not only her symptoms, but I'm also going to be looking into the chart to see what she's grown in terms of cultures and kind of tried to corroborate those prior UTI diagnoses with other kind of more, I would say, objective evidence of infection at that time. And then when it comes to her kidney transplant, that's going to impact our reasoning in so many ways, right? The most simple of which is that we have to remember that her kidney is not going to be in her costa vertebral angles, right? Most commonly, her transplanted kidney is going to be in her right lower quadrant. That's the most common site that kidneys are transplanted. So when we go to examine her and we're going to be looking for what we normally look for as CVA tenderness, we're going to be looking for right lower quadrant tenderness here. And if she has right lower quadrant tenderness, we have to make sure we know that just because she's had a neurogenic bladder and recurrent UTIs in the past, her appendix is probably down there too, right? And so we wouldn't want to anchor on pyelonephritis just because she has tenderness over her transplanted kidney, although again, statistically, that's probably more likely than appendicitis here. In a 23-year-old, appendicitis is sure still on the differential. And so I think we have to maintain a kind of index of suspicion for anything else that could live in the right lower quadrant. The other way that her kidney transplant significantly affected, Yusuf just said we're going to be talking about UTI management in a management morning report soon. So I look forward to hopefully joining then. So, the other way that her transplant history, of course, is going to significantly impact our clinical reasoning here is about her immune status, right? So I'm willing to bet lots of money that because she's had a transplant, she is on immunosuppressing medications. And Yusuf is going to tell us, I'm sure, in a few minutes about what those medications are. But anyone that's on immune suppressing medications is obviously going to have a different ability to mount an immune response than somebody who is immunocompetent. And that's going to impact a few things. Number one, it's going to impact potentially what types of organisms she's going to be at risk for. So organisms that to somebody who has an intact immune system might not cause significant illness, might be, maybe something like an enterococcus, which we usually think about being a relatively low virulence kind of organism, might cause much more significant disease in her. And it's also going to impact her body's ability to mount that response, right? So someone who's on an immunosuppressant might not mount a high fever or a white count in the same way that someone else would. And so again, I think we just have to remain very, very vigilant as we look more into her medications, her vitals, her exam. Many of the kind of classic inflammatory signs and symptoms that we would expect in a patient who's infected might be masked with immunosuppression. And I would usually consider a patient who's immunosuppressed from a kidney transplant to be in kind of the medium immunosuppression range. If we think about immunosuppression not as an absolute black or white kind of on-off switch, but as a spectrum. So a patient, for example, with poorly controlled diabetes, we always say that person might be an immunosuppressed, or maybe somebody on dialysis with end-stage kidney disease. Those patients are immunosuppressed, but I would call them kind of low to mild immunosuppression, right? They're immunosuppressed because of a chronic illness, but usually can still mount those inflammatory kind of signs and symptoms. Someone, for example, who's had a transplant is more in the medium immunosuppression category. Someone who's on cytotoxic chemotherapy for a solid tumor might be in that kind of medium immunosuppression category. And now I'm still even making this more black or white than it is, because someone who's recently been transplanted and just got, for example, thymo induction is going to be more immunosuppressed than someone who, in this patient's case, is 10 years out. She might be on a lot less immunosuppression now than she was 10 years ago, presumably right after her transplant. And then the kind of most immunosuppressed patients are going to be the ones, for example, who have really no bone marrow at all, like, for example, our BMT bone marrow transplant patients. And so I think for those of us that work in academic centers that are taking, tertiary care centers who are taking care of those types of patients with bone marrow transplant, that's like in its whole other world of immunosuppression when it comes to the severity. And so, the types of decisions we make in terms of their prophylaxis, patients who are have recently had bone marrow transplants are going to be getting prophylactic antifungals, antivirals, antibiotics, because they really have no immune system. And so again, this patient is immunosuppressed, although probably less so than she was 10 years ago, right after her transplant, but presumably is still going to be on something like tacrolimus or mycophenolate, which is going to leave her body not able to necessarily mount the same immune response as she would if she had no immunosuppression on board.
Geez, blown away. There was just so much incredible teaching and amazing pearls. Some of the things that just really stuck with me is, like, for someone here who has, a significant past medical history, recurrent UTIs, I really like the pearl you gave about asking, does this feel like the last time you had blank? And all the teaching you gave on the dangers of overdiagnosis of UTIs, the levels of immunosuppression. So really phenomenal. Thank you. Yusuf, okay, let's hear the next aliquot.
Yeah, so just to give a little bit of history as well. So she, in the past, their symptoms of UTI were just having cloudy urine and just the abnormal smell of the urine, which is not typically how we diagnose it, but that's how she reports the symptoms, but does not have dysuria, polyuria, or any other symptoms per se. She does report having cloudy urine and smelly urine in this episode as well. As another background, she reports a social history. She smokes 4 to 5 cigarettes per day, also smokes cannabis almost every day or every other day. Reports intermittent alcohol use, maybe a drink every 2 or 3 days. Lives with her parents, is not working right now, lives in Georgia, has lived in Georgia her entire life. On other review of symptoms, her home meds are tacrolimus, 4 BID, 4 milligrams BID, mycophenolate, 500 BID, and prednisone, 5 daily. And Maddie, if you want, I can jump to exam as well, since we talked about a little bit about tacrolimus and prednisone. So when I evaluated this patient, she looked uncomfortable. She was having some chills when I saw her. So let me tell you the vitals that we had initially. So the temperature was 35.0. The heart rate was 105. The blood pressure was 120/75. She was her oxygen saturation was 95% on room air. On exam, she just seemed in mild distress because of her abdominal pain and just seemed uncomfortable. She was sitting under the blanket. On exams on HENT, she just had a little bit of moon phases, but no scleral icterus or any other things on HENT exam. Cardiovascular exam, she was tachycardic, but did not have any murmurs. She was on pulmonary exam, she was did not have any wheezes or crackles. On abdominal exam, she had mild tenderness, basically under the umbilical area or around the umbilicus, slightly to the right middle quadrant, essentially, and the middle of her abdomen, mild tenderness there. And when I asked where the kidney transplant was, she also reported it's in the right middle to right lower quadrant, essentially. And on derm, she did not have any rashes. And then she was alert oriented ×4, did not have any focal neurologic deficits.
Awesome. I promise everyone that Yusuf didn't tell me anything about this case before. The tacrolimus and mycophenolate was a well-educated guess or assumption. I was just on service last week and had 3 kidney transplant patients, so various transplant regimens are all very fresh in my mind, I promise. It's my turn now, right? Right, Yusuf, you were done with this aliquot? Good, awesome. Excellent. So again, I think the medication's not surprising here, the tacrolimus, the mycophenolate, and the prednisone. Although important to know the dose, right? So, I mean, tacrolimus and mycophenolate are both going to be immunosuppressing. Her dose of prednisone at 5 milligrams is really a kind of physiologic type dose. So that alone probably would not be enough to, to cause significant immunosuppression, although of course, in combination with the other 2 medications, clearly is going to put her at risk. In terms of her social history, I think a few things we already mentioned, but I'll just revisit. One is that she's a, you said cannabis smoker, on a regular basis, daily or every few days, which definitely means she could be at risk of something like a cannabinoid hyperemesis syndrome, although that's really a diagnosis of exclusion, right? So I would definitely not make that diagnosis in this patient without making sure that I've looked for infection, looked for DKA, looked for all these other things that, that would be potentially much more life-threatening and need different treatment. And then the amount of alcohol she drinks doesn't seem to me enough that she would ever be at risk of something like alcohol withdrawal, which could also present with, acute nausea and vomiting. But we do know that patients often do tend to underreport substance use, alcohol included. So I think that's something I'm just going to keep on my list as well in the back of my mind as I'm thinking about what else I need to be doing for her. And then Yusuf, I'm glad you brought us back to her prior, UTI diagnoses. I think, again, in a patient like this, cloudy and smelly urine, like you said, usually we don't use the kind of appearance or smell of the urine to indicate infection, because there's a lot of things that can cause cloudy urine, smelly urine. There's a lot of things that can cause a change in urine color, including things as benign as just dehydration or hypovolemia, which can make the urine kind of dark and smelly. And many patients and family members, especially, will cite that. And I think we really want to look for more evidence, but thank you, Maddie. But that's, I think, where we get to the vitals. And that's when I all of a sudden became very worried about this patient. And so based on her vitals alone, I'm quite worried that this patient has sepsis. She's hypothermic. So, yeah, exactly, Hans. A temperature of 35 Celsius is low, much lower than a normal range, and makes me worried that, hypothermia, just like fever, can be a sign of sepsis. Her heart rate being 105, if she's, again, 23 years old, depending on her baseline level of activity, many of us, I'm not 23 anymore. Some of you hopefully maybe, but, if somebody is young and has a reasonable kind of functional status and is maybe athletic, they might have a baseline heart rate in the 60s or even 50s. And so we don't know what her baseline is, but even if it's 70s or 80s, 105 is clearly a departure from normal. Her blood pressure looks okay for now, which I think is reassuring, although remember that pain increases the blood pressure. And I think we want to make sure that we are not using pain as a pressor here. If she is truly septic, and her actual, her blood pressure wants to be 80s over 50s, but it's only pain that's making it higher. We don't, we want to make sure we treat her pain and then, of course, adequately control her blood pressure as well. Thankfully, the oxygen saturation looks okay. That's the only vital sign I'm reassured by at the moment. And in terms of the rest of the exam, the general part of the exam is by far my favorite and most valuable part of the exam. The kind of NED acronym that you see in far too many notes is one of my big pet peeves. If any of you, my learners are ever on this VMR, but Yusuf, I really like how you really told me how the patient looked to you, because that is just such a window into how worried we should be about this patient. And I think the combination of the vital signs with the fact that she really looked unwell to you should definitely raise our level of concern. And one of the things I always tell my students in their 3rd and 4th years, and then interns especially, is that one of the main goals in those first few kind of clinical years is to try to differentiate between sick and not sick. And I think the vital signs and the general part of the exam are by far the most important data points in making that assessment. And I will just restate, which I did already a few minutes ago, that I'm worried about this patient. I think she's sick. The moon phases are a little bit surprising to me because her prednisone dose, like I mentioned, is pretty low. Prednisone dose of 5, I wouldn't expect to make her kind of Cushingoid, although it's possible she's been on higher doses in the past and she's kind of left with residual Cushingoid symptoms. Tachycardia, again, we had already heard about. And then this abdominal tenderness to palpation. Again, I think statistically, based on what you told us, Yusuf, in terms of the location of her kidney, sounds like she probably has pyelonephritis. Although, of course, we also want to make sure that her pyelonephritis isn't the presenting or isn't the trigger for something else, like a new diagnosis of DKA or diabetes, which, anytime somebody has a new DKA diagnosis, we always want to go back and say what triggered it. So I think this could be just pyelo alone. Transplant pyelonephritis we can talk about in terms of management later if that's where we're going, but usually requires longer courses of antibiotics. We would want to make sure we get blood cultures, et cetera. So I think that it could just be pyelo. It could also be something else in her belly. She could have an enteritis or a gastroenteritis. She could still have appendicitis, although we're a little more umbilical than we are right lower quadrant. She could still be pregnant, right? There's a lot of things that I think we still have to keep on our list. But you're surely painting a good story for transplant pyelo. I'm worried that you're about to throw a curveball in that we'll see where we land from there.
Amazing. All right, back to you, Yusuf.
Yeah, excellent discussion. And it's funny because I was in those shoes exactly. So I was taking this admission and those were the symptoms and this was my exam. And I'm going to give you the labs exactly as it happened and how the story occurred. So basically, I got this admission from the ED and I was the admitting provider. And this was the story that I got and this was the exam. And I'm going to give you the labs that I got immediately on my evaluation. So initial white blood cell count was 17.6. The hemoglobin is 10.2 with a baseline of 8.5. A platelet count of 428, baseline of 232. The electrolytes, so the sodium was 118, potassium was 4.7, the chloride was 81, the bicarb was 6, the creatinine was 8.76, the BUN was 199, the anion gap is 31, so do the calculation. I'm going to give you some advanced labs just to that I got almost soon thereafter. So the serum osm was 332. The urine osm was 304. The urine sodium was 64, with a caveat that this was after fluids in the ED. And then the first imaging that I had was the ultrasound of the kidney, which showed patent renal vasculature and no hydronephrosis.
Anne-Marie very adequately summarized my response with an emoji at this point. So this is a highly concerning set of labs. Yusuf, I very much hope that the ICU block that you said that you're on at the moment was where you met this patient. Maybe. We'll hope. I think you said the creatinine was in the 6s or 8s or something quite high, right? Yeah. Wow. So if I thought this patient was sick based on her vital signs, her labs have surely reinforced that concern in terms of how worried I am about her. I am even more worried now than I was based on her hypothermia, that she's quite sick. So her white blood counts out of 17, again, supports what we've been talking about before, that she could be infected, although, you know, I think non-specific. Hemoglobin, it sounds like higher than baseline, suggesting maybe she's hemoconcentrated. Same thing with the platelets, that could be hemoconcentration, that could also be acute phase reactant. So the CBC is not tremendously helpful here. The chemistry, though, is gonna, I think, be a big anchor point for us. So, and it shows me how big of a gaping hole I had in my, you know, my initial differential diagnosis, which is that we didn't talk about other electrolyte abnormalities, including things like hyponatremia and uremia, as being causes of nausea and vomiting. And I think in this patient's case, that's definitely a possibility in terms of what was causing her symptoms. You know, the hyponatremia, the most important thing first is to figure out whether you think she's symptomatic or not. And in this case, of course, the most concerning symptoms would be a seizure, which we are not hearing about, or any type of mental status changes, confusions, which thankfully it sounds like she's not having. She probably feels unwell from that sodium, but thankfully no symptoms that would need to be acted on kind of emergently. Remarkably, her potassium is normal, and we'll talk about that when we get to her BN and creatinine, as well as her bicarb. So her bicarb being low tells me she clearly has a severe metabolic acidosis, and I don't know if we have a gas, but we can get to that later. But that severe metabolic acidosis could be driven entirely by that acute renal failure. So she has, you know, a very elevated anion gap, and so and a very low bicarb, and so she has what I think is an anion gap metabolic acidosis very clearly, and she has profound acute kidney injury. And of course, we want to look and see whether, you know, what her baseline creatinine was, but presumably after transplant, she should have a, you know, more normal than this creatinine. If she was a patient who was still on dialysis, then a creatinine of 8, I wouldn't necessarily bat an eye at, although I wouldn't really want her to have a BUN of 199. 1.5 is her baseline. So she clearly has an acute kidney injury. And I think the thing we want to think about here is this the primary process, or is the acute kidney injury secondary to something else? And so thinking about her AKI, you know, the acute process and the primary process in her case would be something like acute transplant rejection, which is something I'm quite worried about. Anytime a patient has a history of a transplant and a creatinine above baseline, you always have to make sure that you have thought about rejection. And there's a number of other things that you would want to think about, including tacrolimus toxicity and BK virus infection. But I think a creatinine this high makes me quite worried that she could be in the phase of acute rejection. The other possibility is that, it could be something more secondary, like an ATN from her sepsis. Although I've seen a lot of ATN. I don't think I've ever quite seen ATN with a creatinine of 8. I am reassured that you already have a UA that, a kidney, ultrasound of her kidney, which shows patent vasculature and no hydronephrosis. Because I would say, if a patient comes in with AKI, not with this history with the transplant, but just, new admission for AKI with a creatinine this high, previously normal in the 1s and now 8, 9, 10, the most common diagnosis that I see in that case is actually obstruction. So like in a man who has severe BPH, and comes in with 3 liters of urine in his bladder, those are the patients that I see with a creatinine of 8. This is obviously a very different clinical story. Emery asked, thank you for reminding me, do we have a glucose, Yusuf? Did you put that? I don't see it in that.
Yes,
because
the glucose was normal.
Normal, okay. So doesn't meet, with a normal glucose wouldn't meet criteria for classic DKA, although there is this diagnosis called euglycemic DKA, which is associated most often these days with SGLT2 inhibitors, which she's not on. But I would have to look and think about whether there's any other kind of clinical entities that are associated with euglycemic DKA. I would definitely want to work up that elevated anion gap with things like serum and urine ketones. Trace ketones you already showed me in the UA, although remember that the urinalysis only picks up one of the 2 types of ketones that your body can make. And do not ask me which one, because my brain is not remembering that at the moment. But you would always want to make sure you also get a serum beta hydroxybutyrate to confirm whether or not there's ketones. But it's not sounding like a DK because she's not ketotic. So I think we have to wonder, again, the acronym I learned in medical school was MUDPILES for anion gap metabolic acidosis. I think you guys are being taught something new these days. I won't tell you when I went to medical school, but so thinking about ingestions of certain toxic alcohols, so we would want to calculate an OSM gap to think about whether that's a possibility and make sure we take a good history. Uremia, again, in this case, is kind of screaming out to us as the potential cause of her, AKI. Thinking about diabetic ketoacidosis, which again, we don't think is going on here. Paracetamol, we got a whole list of things that we should think about there. And we haven't even talked about the sodium of 118, guys, except for me telling you I didn't think we needed to give her hypertonic saline because she wasn't seizing. I mean, we could talk, I'm an internist, I could talk for an hour just about hyponatremia alone. Thank you for putting that MUDPILES acronym in the chat, because I started tripping over myself there. But a lot of these things are about ingestion, so we're going to learn that from the history, or potentially checking serum values of things like, certain alcohols, etc. Again, we don't have a lactate yet, right? So it's very possible that this anion gap metabolic acidosis is multifactorial from both her elevated BUN, from her AKI with uremia, as well as possibly a lactic acidosis on top of that. Thank goodness our LFTs are normal, because I don't think we have time to talk about yet another system being down. But in terms of the sodium being 118, again, we want to figure out what her baseline is. We already determined that she's not symptomatic, we think, from the hyponatremia. And then Yusuf already started sharing some of the labs that we would want to check to confirm. So the interesting thing, I'm thinking about this in real time, of course, that the serum OSM is high, right? So most cases of hyponatremia are going to be hypoosmolar hyponatremia, right? So the serum OSMs are going to be low. And that would be kind of things that we often think about, like hypovolemia, tea and toast, etc. The fact that the serum OSM is high tells me that she probably has some other unaccounted for substance in her body. And putting all this together, it does make me worry about potentially ingestion of some type of toxic alcohol, which definitely could give you both the essentially pseudo hyponatremia, as well as the AKI and the anion gap metabolic acidosis. I could be totally barking up the wrong tree here, but this high serum OSM, we think about somebody who's recently gotten mannitol for a, GU procedure. We think about other kind of unmeasured hyperlipidemia, like paraproteinemias. Those are the things that I think about giving you the kind of high serum osms in the setting of hyponatremia. And I would need to pull up a CP solver schema to remind myself what else is on that list.
Geez, amazing discussion of all of those different lab abnormalities. I quickly, just before we jump to the next aliquot, how would you think about management at this case? Would you give fluids? Would you not? What are you thinking in terms of management right now?
Ooh, well, I would be calling my critical care colleagues very early in this case, as well as my renal colleagues. As I was thinking about first steps in management, I would very quickly have them on board as well for a few reasons. Number one is, of course, with the frequency of monitoring required for this degree of hyponatremia in most hospitals, although probably not all, she would probably deserve at least a medical step down, if not an ICU. And then in terms of the, getting my renal colleagues involved, I think because I'm wondering whether there may be some ingestion of some, substance that may need to be dialyzed, I think, I would be thinking about that quite early. Would I give fluids? I think you could try. I don't think it's going to hurt her to give 500 cc's or a liter up front. I don't think that neither her sodium nor her creatinine are purely hypovolemic in origin. So I don't think that that's going to solve any of our problems on its own. But in a patient who I still think in theory could be septic and then now has all these other lab abnormalities, I think 500 cc's or a liter of fluid up front, I don't think would hurt her in this setting. She has a normal oxygen saturation, and as far as we know, probably has a normal heart, although we would also want to make sure that she's urinating. If we had gotten the history, it sounds like we did get the cloudy and smelly urine in the last few days. So if we had heard that she had basically become anuric at home, I would get nervous about giving her fluids because, anything we give her, she's going to kind of third space into potentially her lungs or elsewhere in her body. And I would start thinking about dialysis much earlier. But if she's making urine with these lab abnormalities, I think very small, probably more like in the 500 cc range, especially with that hyponatremia, and then very, very frequent recheck of labs to kind of see which way things are trending. Again, as Yusuf mentioned, the urine sodium of 64, harder to interpret after the fluids were already given. Was she, were her kidneys sodium avid, an hour ago, and now they're not. It's hard to say. But yeah, definitely, infectious workup. So I'm sending blood cultures, I'm sending that urine off to the lab. I'm probably starting empiric antibiotics here, calling my nephrology and critical care colleagues very, very early. And maybe even thinking about, again, small doses of hypertonic saline. Again, she doesn't really have acute indication here, but as we're trying to fix all these parameters, making sure nothing gets worse in the process. I'm not following the math in the chat, but I appreciate that you guys are doing all the math because that's exactly what we would all should be doing if we weren't trying to talk the whole hour.
Absolutely amazing. All right, Yusuf, what other data do we have?
Love the discussion. And I was exactly in those shoes, like holding my breath. But the patient got the fluids, got 2 liters of fluids, and I was holding my breath waiting for the repeat chemistry to see in which direction are we headed in the intensive care unit, as you might have figured. I'm going to give some quick data just because we're going through the time quickly. So I'm going to fast forward. So the urine culture came back positive for strep agalactiae, and E. coli was positive as well there. A CT of the abdomen and pelvis without contrast from the admission was notable for changes of acute interstitial pancreatitis with no evidence of fluid collection. And post-imaging diagnosis of pancreatitis, we after seeing that on imaging, we ordered a lipase, which was 600.
And okay, so maybe this would be a good time to pause and with the CT imaging findings, kind of how do you think through the different etiologies in the context of this patient?
It's 51 minutes into the case for a patient who came in with pancreatitis, with nausea and vomiting, and I have not yet mentioned the word pancreatitis, which is enlightening to me. But But yes, I think it sounds like this patient does meet criteria for acute pancreatitis, both based on her symptoms, as well as the elevated lipase, at least I think it's 3 times the upper limit of normal, as well as the CT findings. The question, as soon as you diagnose acute pancreatitis, though, the question you have to ask is why. The most common things being alcohol use and gallstones, neither of which we've heard about here significantly. And then I would start to worry about how we could put this diagnosis of pancreatitis together with some of the other things that we were worried about a few minutes ago, including, again, ingestion of toxic alcohols, methanol, ethylene glycol, things like that. I don't know actually off the top of my head whether any of those things would cause an acute pancreatitis, although I presume some of them probably could. So I would be looking those things up and then again, thinking about management, whether it's medical antidotes, the names of which are escaping me right now for any of these things versus dialysis for many of them. So again, I think, definitely would not want to anchor on this diagnosis of acute pancreatitis, which she meets criteria for, but clearly doesn't explain the whole story, right? Doesn't explain, acute pancreatitis does not explain her AKI, her anion gap, her hyponatremia, her elevated serum osms. So I kind of have to think that there is some toxic ingestion. Again, we haven't heard about DKA, so methanol, ethyl, ethylene glycol, et cetera, causing the pancreatitis. I do wonder if she's underreporting her alcohol use, which I think could be contributing, but I don't know that it would cause this degree of abnormality. Fomepizole?
All right.
Fomepizole. I think that might be one of the medications you would give for something like a isopropyl alcohol overdose, but I'm going to need to look that up. It's kind of coming, the cobwebs are coming from the back of my mind from when I was an ICU resident more than 6-7 years ago. Thank you, Shema, for clarifying that. Yes, I knew it was back there somewhere.
Yeah, wonderful. And this was like our discussion exactly as well when these results came back. How can we explain the osms, and is there any other reason for the serum osms to be elevated other than renal failure, and keeping that in the back of our minds, the workup of pancreatitis. So like you said, after 2 liters of fluid, the sodium only went up by 1 unit to 119. So that over the next 24 to 36 hours, we did close monitoring of sodium with volume resuscitation and consultation of nephrology, which we're thinking that in the setting of nausea and vomiting for at least a week, could this be due to decreased effective arterial blood volume, and could the BUN be increasing the osmolarity per se for that? So in parallel, as we were working up her kidney function and hyponatremia, we were working up for causes of pancreatitis. Of note, her kidney function improved with volume resuscitation, gradually went down over a couple of days from 8, went back to 2.0. For workup of pancreatitis, so the serum triglycerides were normal, the cholesterol level was normal, and ANA and an IgG4 level were within normal range. A autoimmune pancreatitis panel was sent and was normal. Of note, I didn't mention earlier, the alcohol level was also normal, and an extended urine drug screen was also normal. We had an infectious workup for both like renal failure initially. Could have this been like an infectious etiology for like a BK virus, and adenovirus PCR were also negative. Coxsackie antibody, I believe, was normal as well for infectious causes of pancreatitis. EBV and CMV were within normal limits. The TSH was within normal limits, and all the workup essentially was within normal limits. Ultrasound of the abdomen did not show gallstones either, and the patient improved with like IV hydration over a couple of days. Essentially, her symptoms resolved, and her sodium went back to normal after a couple of days as well. I don't know if you have any thoughts to add before I say what we did or what the presumed diagnosis was.
The only thoughts is just that I'm impressed by the human body and human physiology, which is that I very rarely will attribute a sodium less than 120 and a creatinine of more than about 2 or 3 to hypovolemia alone. But it sounds like in your guys' management, that's ultimately all she responded to was volume, which is just impressive to me. Diagnostically, I'm curious to hear what you guys did, because I would have to remind myself again when it comes to things like these ingestions, how many of them you can measure levels for versus whether your diagnostic test is going to be an additional question on her history that's going to cinch the diagnosis. But thankfully, it sounds like, I mean, also just a kind of remarkable example of how young bodies, even if they've been through a lot like this patient has, can recover quite quickly from very, very acute illnesses. So I'm really glad to hear that a lot of her lab abnormalities improved with just fluid alone. But I'm still wondering what the ultimate diagnosis is here, because again, I think there's a few diagnoses in terms of toxic ingestions that might have connected the pancreatitis with some of the lab abnormalities, but we haven't gotten confirmation of that yet. And with 1 minute to spare, Yusuf, I'm going to give you the floor back.
Yeah, thank you. So the team talked to gastroenterology as well, who were thinking similar to you of could there be a review of supplements and review of medications, thinking of any cause of pancreatitis. And essentially all the lab workup returned negative. And like the people in the chat are saying, we went to do like a deep review of the medicines that she's taking and like cases of pancreatitis. And causation in general is very hard to elicit. And there's like classes of drug-induced pancreatitis per se, and some are class 1 causes where the medication is stopped, the pancreatitis resolves, and they give it again, patient develops pancreatitis. These are class 1, while class 4 causes of pancreatitis are where there are case reports of medication-induced pancreatitis. So there are only case reports of medication-induced pancreatitis and the causes of mycophenolate and tacrolimus, like less than 10 cases per se. However, there are more than hundreds of cases for cannabis-induced pancreatitis. And apparently it's one of the medicines that's classified under class 1 under with the review of the literature. So the presumed diagnosis was cannabis-induced pancreatitis. The patient was discharged with follow-up with gastroenterology in a couple of weeks. And I've been following the chart. Their symptoms have completely resolved in the interim, but this is like a presumed diagnosis, and pending if we see anything come up in the future, I'll definitely keep you posted, but this is the diagnosis that is presumed at this point.
Absolutely incredible case, Yusuf. Thank you so much. I want to be mindful of everyone's time. So Rebecca, I'm going to turn the mic over to you just to get any last reflections you have and like kind of any points you want to highlight before we end the session.
Hi, everyone. My 4-year-old would like to join us for this last part, and he's wearing his clean underwear on his head. Can you say hi, everyone?
Hi.
This is like such a fascinating case to me. And I think, Yusuf, I'm glad that you talked about the process that you and the team went through together, because anytime I have a patient who's admitted with pancreatitis and there's not a clear trigger like alcohol or gallstones or hypertriglyceridemia, I always start to I look up their medications, right? And I've been through the exact process that you just described, which is that, you can find almost any medication that's been associated with pancreatitis. And part of me always wonders, like, how did someone make this association, right? Like, why not call this idiopathic? Why call it medication induced if they were on 6 medications and you're just going to blame one of them, right? And so I really always struggle with that kind of diagnosis of presumptive drug-induced pancreatitis, because how do we know that this was the cannabis and not the mycophenolate? We don't know, right? And it obviously has huge implications for this patient and for many others when it comes to deciding whether or not they should continue, or resume a medication that maybe 5%, 10% chance was the cause of their near fatal pancreatitis. And I do struggle with this question a lot. And when I feel like I can't come to the decision on my own, I will often, ask a gastroenterologist about it or ask a specialist who prescribed the medication of interest and say, how have you ever seen this before, et cetera. And yeah, I think I'm just similarly kind of perplexed often and feel like I'm at a crossroads when in terms of management. What do we call this? Do we call this cannabis-induced pancreatitis? Do we call this mycophenolate? Do we call this idiopathic pancreatitis, right? I think reasonable to counsel her to, stop using cannabis. This is something I do. I mentioned very early on in the hour about cannabis hyperemesis syndrome. I often tell patients, I had one literally last week that I admitted. I was like, I don't know if this is what you have, but the only way that I can make this diagnosis is having you stop smoking and see what happens. And I guess you kind of make the same kind of counseling attempt here as well. And that seems like a more benign thing to do than, for example, to stop her transplant immunosuppression. There are other options for her, you know, thinking about something like azathioprine, which I don't know on its own whether that has a risk of pancreatitis. And you would also want to do, I don't know if you guys did this as well, a kind of anatomic workup. So to think about doing an MRCP to make sure she doesn't have pancreas divisum or some other anatomic reason that she would have had pancreatitis. You know, I think you guys probably went through that whole, you know, that whole evaluation, but it's really hard when you're making a diagnosis like you guys ultimately did. That's kind of in a way a diagnosis of exclusion, right? You've had to check off the 8 to 10 most common causes of pancreatitis and then make a educated assumption as to what the most likely thing was. And this patient got quite sick from this. And so I think her, you know, one of the things that I would do as I'm discharging her is just a lot of counseling around what to do if she has recurrent symptoms, right? I think you told me that she had about a week of symptoms, but in a patient that got this sick from pancreatitis, I would tell her at the first sign that she starts vomiting at any point in the future, she should come immediately to get medical attention, whether that's at her nephrologist's office to at least get a set of labs or to an ER as soon as she can't tolerate food or fluids, because regardless of the etiology of her pancreatitis, whether this is cannabis or idiopathic or whatever, her body has proven that it has the ability to get quite sick. And so I think that's a big part of my management in this patient is about patient education and anticipatory guidance about what happens if this happens again.
Thank you so much, Rebecca. I'm really blown away by the thoughtfulness and kind of quality of teaching and how kind of authentic you were in your reasoning. So really, really appreciate this incredible discussion. And for the sake of time, we will end the session there, but I encourage you all to check out the incredible teaching points by Shema. We'll post the whiteboard on the website. But thank you, Yusuf, for the incredible case. Thank you, Rebecca, for really a remarkable discussion. And thank you all so much for tuning in.
Thank you guys so much for having me. Everyone enjoy your evenings. Thanks for being flexible in the time to accommodate my my little monster's bedtimes. And hopefully we'll get to do this again soon.
Definitely. Bye, everyone.
Bye, guys.